I'll take the honors of starting up the program as Dr. Schiller is not present today. Let me welcome all the faculty and delegates who have joined today. Dr. Rajesh, good evening. Welcome. Dr. Rajesh will be moderating the meeting for today. Over to you, Dr. Rajesh.
Yeah, okay. So
my
topic is understanding cartilage lesions of the knee joint and its evaluation. So I think I'm not going for too much of details because much of the management will be covered by the two next speakers. So understanding cartilage lesions of the knee joint and its evaluation is very important in terms of an arthroscopic derived embryologically from mesenchyme and that become imprisoned within this matrix become chondrocytes. And the articular surface of most synovial joints are lined by hyaline cartilage. So this is the zones we can see that the zones is on the top, the intermediate zone and the deep zone with the tight mark over there and the calcified cartilage below. So the cartilage histology, there is 80% is containing water, and type 2 collagen and glycosaminoglycans which are relatively charged. So subchondral bone provides nutrition and is often underrated. The composition and structure of a cartilage consists of matrix and cells, and the water mainly 80%, collagen, proteoglycans, glycoproteins, and chondrocytes. So relatively hyaline cartilage is acellular. Mostly type 2 collagen is not vascular. There is no vascularity there. There is no neural component, so it won't feel much pain. There is no lymphatic supply, and it is little capacity to heal after injury. So if you get a cartilage injury, there is high chance that it won't heal. And it provides a low friction surface and a lubricated surface, and it's slightly compressible and elastic. When you probe arthroscopically, you can see that it is slightly compressible. The cartilage is slightly compressible over there. And this is a modified outer bridge classification. So this classification provides just an outline of what you can have as a cartilage lesion. That is, grade 0 is a MR imaging. It shows a homogeneous and smooth delineation. In arthroscopy, it shows uniform thickness and intact surface. And it's a normal cartilage. Yes, schematic representation is shown on the right side, where you can see that it's fully, there is no cartilage loss. So in grade 1, you get focal areas of hyperintensity with a normal contour and softening or swelling. That is, in MR, you can see focal hyperintensity with normal contour. And some small lesions are seen. And type 2 is a blister-like swelling or fraying of the articular cartilage. That is type 2. And it is a superficial defect, less than 50%. And grade 3 is a partial thickness cartilage loss with focal ulceration, and it has a deep defect of more than 50%. So that is 3. And 4 is exposed subchondral bone. So cartilage destruction with exposed subchondral bone is full thickness deficit is outer bridge grade 4. So what happens to an injury? What happens to cartilage when an injury occurs? That is, go for chondrocyte degeneration with matrix destruction. And there is no hematoma because it is washed out by the synovium. There is no fibrin and no inflammation and no undifferentiated cell supply. So the cartilage mostly goes for fibrocartilaginous healing method maybe. And what happens is that there is, even if it proliferates, it gives an incomplete and short-lived response. So if the cartilage, again, it proliferates, try to form a fibrocartilaginous structure, it gives an incomplete and a short-lived response. The symptoms are mostly pain, and most commonly it's increased with weight bearing, swelling, and mechanical symptoms. So cartilage is the most important biomarker with traumatic and degenerative disease. So it's clinically a trauma of significant origin, point tenderness, and associated with ACL or MPFL injuries could be associated with the cartilage lesion. Degenerative tears are also associated with it. So what you can get as a sign with while aspirating, you can get fat globules, which might be a suggestion of a subchondral injury or subchondral fracture. So there are not much specific tests for cartilage because cartilage as such doesn't have any positive test which we can elicit and we can find out a cartilage lesion. And MRI is the most best good imaging modality. So early degeneration is seen as fibrillation, pitting, or fissuring in MRI. Then it changes into partial thickness and then full thickness lesions. So 1.5 Tesla is quite inadequate to diagnose cartilage lesions. 3 Tesla is sufficient, and the cartogram sequences are useful. So MRI, what you see, sometimes you see as subchondral bone edema and seen as high T2 signal in, and the T2 gradient sequences are there. Some things that like T2 star, SPGR. On histology also, the marrow necrosis and trabecular disorganization is also seen. So subchondral bone is quite underrated because sometimes you see a subchondral edema in cartilage in MRI, and we might think that it is okay, but subchondral bone is quite a pathological thing, and subchondral edema which persists are harbingers of cartilage injury. So, and that has got significant relation with pain. So if I tell all these things, that is 2D fast spin echo sequences, these are used for cartilage diagnosis. T2 weighted fast spin echo sequences, delayed gadolinium enhanced MRI imaging, T2 mapping, and flash, that is fast low angle splash sequences. So this is all maybe rocket science. Maybe it is too much. I tried to read it, but it went over my head. So I don't think all these things will help you in diagnosing a cartilage lesion in MRI. So I'm not going for this rocket science, and I just checked what is T2. So this is the definition of T2. That is a transverse relaxation time. It's a time constant which determines the rate at which the excited protons reach equilibrium or go to outer phase with each other and all. So this is too much. I think we shouldn't read this too much because it might completely knock us off. So what exactly are we planning? So we are not going to do any rocket science. We want to know whether the patient has got a cartilage injury. We want to see how the cartilage looks like in MRI. So it's a simple thing. You can just see this man. This guy is Hitler, and he created World War II. So according to it, T2, what is T2? How can we identify a T2 sequence in an MRI? So it's simple as that water looks T2. We can just simplify it as an acronym. That's WW2, World War II. So water looks white in T2. And just I put this image of Hitler so that you don't get confused with the World War I. It is World War II. So water looks white in T2. So from this statement, I wanted just to know that how to read an MRI cartilage in. After this session, I will be really grateful if anyone can identify more cartilages in MRIs. So this is a typical sequence in which we can identify the cartilage. Here you can see that the water looks white. Here, this is a meniscus, as we all know. We usually read all the MRIs ourselves. We see cartilage, we see meniscus, we see ACL. We don't much see cartilage because we don't look for it. That is exactly the reason we don't see cartilage, because we don't have to operate on cartilage alone. So that is why we don't look into it. So if you look carefully, you can see the cartilage. So this is a T2 image. There, see, it is looking white. I think that my arrow is visible. So in this arrow, you can see the water there. This is a meniscus, and this is the cartilage. This grayish thing which is surrounding the bone is the cartilage. So this cartilage is very nicely seen over here. So this is a cartilage in the femoral condyle, and here you can see that on the tibial condyle also. So these two are the cartilages in this bone. So if you first of all identify the grayish matter that has gone over here. I think my arrow here, right? My pointer is clear, right? This is a pointer which I am showing. So this is it clear?
We can see you.
Clear.
Yeah. So this is the cartilage. This is the entire cartilage, and from here, this portion is the cartilage loss. White, sir. Sujit, sir, I think is my pointer clear?
Yes.
Yes, it's very much clear.
Okay.
Good.
Okay.
We
so
can
in
see
this in this one, this is a cartilage loss over here, and in this film, you can see that there is a big cartilage is okay over here, and here it is almost no cartilage there. Only the white fluid is touching the bone, subchondral bone. That is, the synovial fluid is directly touching the subchondral bone. The white thing is touching the subchondral bone, and there is subchondral edema. You can clearly see that there is absolute cartilage loss in this portion. So here, the another thing is that same thing. There is a cartilage is gone here, then there is subchondral edema. And here, this is a field of T2 mapping, which I told. T2 mapping is another sequence which is used for cartilage imaging. And here also you can see there is some subchondral edema. Here another one. This is another cartilage injury. This is a cartilaginous portion and there is a cartilage injury here. The white fluid has seeped inside and you can see a cartilage injury clearly. Here in this underneath surface of the patella, this much portion has cartilage. See that gray portion. You can see the gray portion here. But here the cartilage is lost. And here there is total loss of cartilage. So thing is that once we know the cartilage where it is, in an MRI sequence, after an arthroscopy, you can just come back initially and look where the cartilage was lost. So that will be a good thing to assess. So you can identify the cartilage lesion after arthroscopy, and you can again brush up yourself to identify more cartilage lesions so that you can identify them pre-op also. So this you can see once again, I am just going through all these things because this is the most important thing I wanted to convey. I just want everyone to see whether the cartilage, where it is exactly and how it looks like. So I don't want to go to any rocket science in this. So this is how the cartilage looks and this is what you get. And MR arthrogram, you can do it. Obviously, in papers, it is written that it gives enhancement, but you never do a MR arthrogram. In our place, it is very difficult to convince for a patient to do an MR arthrogram to assess a cartilage lesion, I think. So it's practically very difficult. Just because the glycosaminoglycans are positively charged and this repels the MR arthrogram molecules, it gives a very clear picture, it says. Even our radiologist doesn't feel that he can do an MR arthrogram and diagnose cartilage lesions. So another thing is bone marrow lesions. The bone marrow lesions are the least understood things in cartilage lesion because these things are mainly hyperintense lesions seen in trabecular subchondral bone with increased mechanical stress. So these are increased seen in T2 weighted images. So what are bone marrow lesions? So this is what actually, when you don't see the danger beneath, it could be even a Titan or Titanic, it will sink. So that is what I want to say, because the subchondral bone is the most important thing to deal with a cartilage injury. When you are repairing it, if the subchondral bone is not addressed, then definitely you are going to fail. So a typical example is osteochondrous desiccans. You can't just fix an osteochondral desiccans like just a traumatic fracture or something like that, because the subchondral bone is the culprit in a osteochondrous desiccans. So you can see there it's a subchondral bone underneath is involved there, and the cartilage superficially might be looking all right in the initial time, but later on, if it goes down in osteochondrous desiccans, if you try to fix it, it might not work. And moreover, if you are doing you have a bigger lesion, then obviously you should support the subchondral bone also, just like OATS, or you can't do a simple microfracture and get away with it. You need to replace the subchondral bone. That is why you are doing OATS in a bigger lesion and rather than a microfracture in a smaller lesion. And learning from osteochondrous desiccans, everything begins from the subchondral bone, and so does healing. So you should be aware that a subchondral bone might not be good, and histology has proven that subchondral bone edema, if you take a histology from that portion, it might cause a disorganized trabeculation, avascularity. All these things are histologically proven parts of subchondral bone edema if you take a biopsy and study it. So this is just regarding subchondral bone. That is just a newer version of a microfracture. It's a nanofracture. It's called a nanofracture. You do one in an usual our chondral pick. It goes 3 millimeter deep and 2 millimeter width. But in a nanofracture, it is 1 millimeter deep and it goes 9 millimeter, 1 millimeter breadth, and it goes 9 millimeter deep. So it is addressing the trabecular channels and pluripotent stem cells down the subchondral bone. So this is called nanofracture, and this is an instrument used for that. So a step more than microfracture, you can say nanofracture. So this will harvest more pluripotent stem cells from the subchondral bone. And some other things which addresses subchondral bone is osteochondroplasty. This is also a newer technique in which you use the subchondral bone to heal better and provide a more stable, maybe a stable environment for the cartilage to grow. So it's called osteochondroplasty. You diagnose it, you take it. This is subchondral bone edema. You put a needle there and take an iliac crest from there you can take bone marrow and you can aspirate and condense it, and you can take bone plugs also, and under CM guidance you are injecting it directly into the subchondral bone. That is called osteochondroplasty. So it's a newer treatment for subchondral bone edema which can cause persistent pain. So this is pictures of that. The bone marrow aspirate is taken and bone dowel autograft is taken and it is injected into that place under CM guidance. So moreover, arthroscopic evaluation is obviously the gold standard for evaluating cartilage lesion. There's no doubt about it. Only arthroscopy can identify it. You can measure it, you can quantify it. But everyone knows about arthroscopy, how you see a cartilage and all fraying. This is a fraying, you can see grade 1, grade 2 lesions. This is a small total complete full thickness cartilage loss. And you can measure it with the probe. That is the most important thing. You can assess it. You can know where exactly it is. And this is a small video. I don't think whether it will run or not. Is it visible?
Yes.
Is the video visible?
Yes.
Yes, it is.
Yeah, okay. So in this probe, we are seeing that fibrillation. This is a type of cartilage, initial cartilage injury. You see the fibrillation type of cartilage. And earlier, after that, this is a portion where it has been healed by a fibrocartilage. So actually, in this case, I tried to just probe onto the fibrocartilage so that, see that I'm just probing it and it is coming out. Simply, the fibrocartilage is just coming out and the subchondral bone is. So it is so much flimsy. The fibrocartilage doesn't have that much of a power to heal. So when I'm probing it, it is just simply coming out like that. You can see that very well. So this healing is not proper. So we need assisted things to heal for the cartilage. So we should heal. We should learn to read an MRI cartilage where it is gone. We should address a subchondral bone and we should do proper treatment for both. So that's all. Thank you so much for your patient listening.
Thank you, Dr. Jothiprasanth, for a very informative talk. Actually, it is we got some idea regarding how to diagnose cartilage lesions. And the topic is open for discussion. If any doubts regarding the first lecture, you can ask questions to Dr. Jothiprasanth.
I think Jyothi gave a clear idea about MRI. In MRI, always we see the cortical bone as a very dark image. After that dark image, you will see that grayish structure, that is the cartilage. Whether it's T1 or T2, the cortical bone always look black in MRI. Next to that black structure in the surface is the cartilage. I think you very nicely demonstrated that. Unless we look for it, we will miss those things. Cortical bone, tendon, ligament is dark in MRI. And cartilage looks, because cartilage is got 80% water, so it looks more like whitish structure. Or it looks like slightly grayish structure.
Dr. Jyothi, is there any, what is the difference between a traumatic cartilage lesions and the degenerative cartilage lesions? Whether we can differentiate just by arthroscope or by MRI?
I think that
in MRI, traumatic mostly, sometimes it will have this subchondral edema will be persisting. And moreover, usually it will not be alone. That is, single traumatic lesion will be usually there in a trauma. But degenerative will have the entire cartilage will be a degenerative type.
Okay.
So please.
Yes, come on.
Yeah, talking about the knee joint or cartilage, can you elaborate on the thickness of cartilage in various areas of the knee joint, the lateral compartment, medial compartment, and the patellofemoral?
Actually, thickness varies. Actually, different. You can't exactly tell because different patients will have different thing. The thing is that we should mostly anterior femoral condyle is very thin. Lower and posteriorly it becomes more thicker. So anteriorly it is thin. So mostly in the if you see the routinely MRI, the below portion and posterior portion becomes thicker. And tibia usually below the meniscus, it is only thin seen. So mostly it is the femoral condyle which has got bigger cartilage structure, thick one.
And the patellofemoral is more than the femoral condyles.
Yeah. Patellofemoral also is
Medial has more cartilage.
medial is more cartilages. Yeah.
Medial has more than the lateral.
Yes.
Actually,
among all the cartilages, probably the patellar cartilage is the thickest one.
Yeah, patellar cartilage is the thickest part. And in femoral condyle, the down and posterior portion is the thicker part. Anterior portion is more thin.
patellar's articular thickness is supposed to be up to 5 millimeters.
Correct.
Yes.
Probably thickest articular surface
That is patellar.
normally.
Yes. Patella is the thickest articular surface.
What is the importance of
This
this
talk is really relevant because
come on. There is a calcified cartilage layer in between the cartilage and the subchondral bones.
Yeah, there is a calcified cartilage layer.
But any relevance or importance regarding the pathogenesis?
It's normal in normal cartilage itself that one layer is seen.
Yeah. Okay.
So that is the deepest layer of the cartilage.
Deepest layer of the cartilage.
I think what he is trying to say, calcified cartilage layer, if a lesion is going deeper to the calcified cartilage, then the whole vascularity is gone.
Yeah.
You need it. They are called as deep lesions. The one that is superficial to calcified cartilage can be a very superficial one, like a grade 1, grade 2 one, where they have a chance of the nutrition for the superficial layer comes from the synovial fluid. The deeper to cartilage layer comes from the subchondral bone normally. There is a basic science behind it. So any lesion beyond cartilage, calcified cartilage layer means then it's a very deep damage to the cartilage.
Okay. If there is no more question, we will go to the second topic. I made Dr. Murukan Babu, head of the department of and arthroscopic surgeons, Rajagiri Hospital, Kochi, to talk on microfracture and OATS, my algorithm for treating small and large cartilage defects. Welcome, Dr. Murukan.
Thank you, Dr. Rajesh, and thanks for the ask. And so my topic is cartilage lesions of the knee, microfractures and OATS treatment. Yes. So we all know that the articular cartilage is unlike the other musculoskeletal tissues. It is not. It has not got that much potency for healing capacity. It has got a low self-healing capacity because it is a vascular, or it is hypovascular. The extras, because the tissue contains histologically it's an abundant extracellular matrix with the low cellular density, and this abundant matrix actually obstruct the stem cells migration and prevents cartilage regeneration. So once a cartilage is injured, it progressively lost its tendency to heal and the potency of resisting the load, and even it eventually results in a joint osteoarthritis. So this is the basic anatomy. Dr. Jyoti has beautifully demonstrated the layers. These are 4 layers of the cartilage, and the last one is the deeper one is the calcified. And this is the modified outer classification with grade 0 to grade 4. The grade 0, there is only thinning of the cartilage, and the grade 4, the subchondral bone is exposed. The grade 4, the subchondral bone is exposed, and the osteochondrous, the secants, and all the subchondral bone is also involved. So, coming to the treatment part, the investigation part, Dr. Jyoti has beautifully covered the MRI and all. Then mild symptoms, you can give the period of rest for NSAIDs, and even you can try a hyaluronic acid injection. And most of the cases, because they have low healing potential and also the presentation may be late, the surgical treatment is required. The operative treatment of this cartilage lesions depends on the thickness of the cartilage, the thickness of the injury, so whether it's a partial thickness injury or a full thickness injury, and size of the lesion, we will come to that, and the activity level of the patient. So in high demanding patients, the treatment is different. And the surgical treatments for partial thickness are, you can do debridement and chondroplasty and fixation of unstable osteochondral fragments. And in full thickness, you have this microfracture and OATS. So that is the two things that we'll be discussing in the remaining part of the talk. And other things are the allograft transplantation, ACA, and autologous matrix-induced BMAC implantation, and other things. And all these treatments actually depends on these four basic techniques, like the stimulation of intrinsic healing potential. The body's intrinsic potential is actually augmented by giving certain things like the microfracture. The microfracture actually comes in that heading. Then alteration of joint loads, that's OATS treatment comes under that, and transfer of autogenous tissues and transfer of allograft tissue. These are the basic four techniques of treating all these full thickness cartilage lesions. So among this intrinsic healing potential stimulation, you have the drilling and debridement, then abrasion arthroplasty and microfracture technique. So the microfracturing, actually, this was originally designed for post-traumatic full thickness cartilage lesions and also been applied for osteochondritis dissecans. Usually at that time it was thought to be useful only for less than 2.5 centimeters square of the lesions. And I've heard about this International Cartilage Regeneration and Joint Preservation Society, because they have given and they have actually postulated and given some ideas about treating these microfractures and the odds in cartilage lesions. So this one is a main forum for international collaboration of cartilaginous tissue research and joint preservation. It has got around 1,200 members from 65 different countries. And this group represents a global cross-section of knee surgeons treating chondral pathology. So this can be considered as probably a final word or a very good suggestion from this ICRS. So they have taken into consideration different things. One is the size of the lesion. So in this, they have, this is just a survey-like thing. So about 55% of surgeons included in this study, they say that they do this microfracturing for lesions less than 2 centimeters squares. But the another 35% people do up to 4 centimeters squares. So if you look at this graph, this pie chart, so in so the dark one is the less than 2 centimeters square percentage, and in North America most of them do only less than 2 centimeters square of the lesions, and in Asia Pacific regions almost this both up to 4 centimeters square lesions are being treated by microfractures, and this is the regional difference. So in Asia Pacific, that is the fourth one. So the Asia Pacific, you can see most of these lesions are treated by microfracturing. So the obvious that this is due to the economic, the financial aspect. The OATS requires more, it's a expensive treatment. And so microfracture, the same to the other side of the coin, the North America. So the microfracturing is less, and they do more cases of AC and OATS. And age limit, and 50% of the surgeons reported no upper age limit for the use of microfracturing, and 25% they would use microfracturing in patients older than 60 years. And BMI, in the similar way, almost half, around 50% of respondents do not have an upper BMI limit. They do for all patients, but 22% would perform surgery on a patient with BMI less than 35 kilogram per meter square. And malalignment, so around half of the surgeons agreed 3 to 5% at the maximum degree of uncorrected angle. And another 30% would perform microfracturing with more than 10 degrees of malalignment. And the site, about 40% of surgeons perform tibial plateau and 35% of the patella microfracturing. And most of the majority all agree with the microfracturing of the femoral area. The high level of athletes, so 24% respondents were not willing to perform microfracturing on high level athletes. And the instrument used, and about 70% of people, the surgeons use microfracture all, and about 17% use Krishna wires for this microfracturing technique. And coming to the rehabilitation, and most of them restrict weight bearing following this microfracture, and the partial weight bearing after 2 to 6 weeks, and unrestricted return to activities at 4 to 8 months post-operatively. You see, majority suggestion about rehabilitation. So this was about the ICRS probably suggestions, and this paper, the JBJ's paper in 2021, it's a current concept review with contributions of microfracturing. So the indications on the left hand side, so it's not that visible. This is the enlarged thing. So lesions less than 2 centimeters square in size, attribute 3 and 4, and lack of subcontinental involvement. So we are discussing about that. So this microfracturing, actually, this paper says only for people having a lack of subcontinental involvement and active patients and lesions confined to the femoral contact. This was the indication given in that paper. And we all know that microfracturing, this is the marrow stimulation technique achieved by subcontinental bone perforation to recruit autologous mesenchymal stem cells to a cartilage defect. These stem cells differentiate into fibrochondrocytes, which fill and remodel injured area to form a fibrocartilaginous clot. That is the science behind this microfracturing technique. These are the instrument used, and this is a small video actually. This loose cartilage around this area should be removed using ronges or curettes and all, and the stable cartilage should be there, and you can start putting these holes in the subcontinental area. This is microfracturing. Probably the future will be nanofracturing and other things as demonstrated by Dr. Jyoti. So this is the microfracturing technique. So there should be a stable cartilage all around. That is more important. And this is the schematic representation. When you do this all, so the bone marrow, from the bone marrow, the bone mesenchymal stem cells and red blood cells fill that area of the defect, and that will clot is formed, and later it will become the fibrocartilage. So the second part is the OATS. You are altering the joint loads. So in patients who desire a higher level of activity, that is like sports people and all, you can try this osteochondral autograft transplantation. So here, the transplanting a single round cylinder of articular cartilage and underlying bone, and the harvested graft is from a minimally weight-bearing part of the joint to the area of the cartilage defect. This can be done either by open or endoscopy methods. And the same paper, the 2021 JBJ's paper. So here, so this is a first-line treatment for defects of less than 2 centimeters square with grade 3 or 4 attribute classification. So they have given us the first-line treatment, and with subcontinental involvement. That is indication for this OATS treatment in active young patients. The broad indications are age younger than 50 years, both BMI less than 35, previously unsuccessful conservative surgical interventions, grade 3-4 osteochondral defects, then normal correctable ligament stability, meniscal integrity, willingness to comply with the rehabilitation protocol, and realistic post-surgical expectation. These are given in the textbook as the indication for OATS procedure. The advantages are there is no risk for disease transmission, there is no problem with rejection, and higher rate of union and fresh graft viable chondrocytes. These are the advantages. The benefits: the whole tissue transfer of subcontinental bone and the mature hyaline cartilage to the needed area. So autograft transfer has been shown to provide good to excellent results with short-term follow-up. Then disadvantages: the supply of expendable autogenous osteotic tissue is limited. So even a very large defect probably may not be able to fill that area. So because of the limited of the tissue, and sometimes donor site morbidity and long-term results suffer from plug loosening due to degeneration of interplug fibrocartilage. So these are the contraindications of OATS, like large and deep osteochondral defects, arthritic or degenerative lesions, lesions with areas of unstable or semi-detached surrounding cartilage, then angular deformities, untreated instability, and major meniscal deficiency. So here, this is the OATS. Here, the subcontinental bone, the bone marrow cells are, the red blood cells are sweeping into the into the area, and that will fill the defects. The graft harvest is usually from the just anterior to the sulcus terminalis, that is applying the articular area of the patellofemoral joint and the tibiofemoral joint. So anterior to the sulcus terminalis is the area where you should look for the donor site, and so this can be done in arthroscopic techniques. You can use these standard portals, and you can extend these portals to take the donor to reach the donor site and also the recipient area. And our sets can be used to take out this. These are some pictures, and the arthroscopic pictures. This is the just anterior to the sulcus terminalis, and this is the after the donor after the blood has been taken from the donor side. And this is the medial femoral condyle, the lesion, and the medial femoral condyle. This is the measurement of the depth of the lesion, and a donor graft is placed using an impactor, and this is the final picture. And this is a very beautiful demonstration. This is taken from the internet, so I have done 2-3 cases, but I didn't get this much of perfection in those cases. And coming to the comparison of this OATS and the microfracturing, and at short, medium, and long term, so 10-15 years, OATS results in better clinically relevant outcome than microfracture in articular cartilage defects, covering areas 2 to 5 centimeters square in 18 to 50 years. The another study, they also say that the OATS procedure is superior to microfracturing. And this paper, this Goyle the paper and systematic review of level 1 and 2 studies, they said that 5 years after surgery, microfracture treatment failure could be expected, regardless of the size of the index contra lesion. Another paper, microfracturing has been associated with the inability to maintain clinically meaningful pain relief at 5 years post-operative. This paper is also, almost all the papers available in the literature favor OATS treatment compared to microfracturing. And even so, we think that the microfracturing is economically viable, but 2 papers, they say that. So that is also economically not viable, because most of the time you may require a secondary procedure like OATS or some other procedure. So the total cost will be more if you choose microfracturing. Then there are 2 papers like that. So this is the flow chart given for different lesions, the patellofemoral lesions and the femoral and tibial lesions. And most of the time, the lesions, if it is less than 2 to 3 centimeters square, you can use both microfracturing and OATS. And larger lesions probably may require other types of repair that will be dealt with Dr. Subramaniam. And in conclusion, microfracture is effective for cartilage lesions without subchondral bone involvement, up to 4 centimeters square, even more, but long-term deterioration can be expected. OATS are effective up to 2 centimeters square lesions with subchondral bone involvement, and OATS may be done in young age with high-demanding patients. Thank you.
Thank you, Dr. Murukan, for a very informative and a database talk regarding the OATS and microfracture. And we also described the postoperative protocols in both cases, and it's very well. And now the topic is open for discussion. My first question is to Dr. Murukan. Actually, in a microfracture, we are actually drilling the bone or specking the bone. What is the correct way of?
Subchondral drilling and microfracturing are different techniques. One is subchondral drilling, that is drilling alone. But microfracturing is just using, actually you are poking, you are using just tapping with the smooth tipped instruments like the owl or a K-wire. The drilling is different. That also, actually, as per my talk, that also it augments the self-healing capacity of the subchondral area to repair the cartilage. But all means this the microfracturing is better than subchondral drilling.
So how much depth we have to go then if you are preferring an old?
Usually 5 millimeter. So probably, so as per this nano technique, probably if you go even beyond that, probably the subchondral bone, more the stem pluripotent cells may come to the surface and it may hasten the chondral healing. I don't know. So as per this nano fracture.
So nano technique is more preferred than microfracture, or?
Yeah, nano technique. Even in chondral lesions, nano technique is coming into place.
About the depth of OATS, would you change the depth of the donor plug and the recipient area in case of a chondral lesion versus an osteochondral lesion?
Yeah, definitely, definitely.
Osteochondral is different.
Yeah, definitely. So that the MRI, so you need to see the MRI and how much depth of the subchondral bone is involved. So microfracturing, that is the basic difference between this microfracturing and this OATS technique. The microfracturing, you are dealing only with the cartilaginous lesion. You're not going into the subchondral area. Even though you are poking into the subchondral area, that subchondral bone should be normal, physiologically normal for this growth. But in OATS, you can go up to 15 or 20 millimeter depending on the amount of subchondral tissue involved, the pathological subchondral tissue involved. So you need to take that plug out and put the new physiologically viable subchondral bone from the donor side. So for that, I think you need to look into the MRI carefully and how much depth of the subchondral bone is involved. And depending on that, you can increase or decrease the thickness of the bone plug.
Dr. Subramaniam, you're not
mute.
Yeah. You're muted. Yeah.
No, the microfracture probably is a commonest operation most of us do in terms of cartilage.
Yeah.
And
exactly.
The owl has got a conical end. The conical end enlarges at one point. So because it's a conical, isn't it? It enlarges at one point, and that place we stop it. Usually a depth of about 3 to 5 mm, as Dr. Murukan Babu was telling. That's where you stop it. And that point you start seeing fat globules coming out. Fat globules coming out is a good signal that we are going to get to the mesenchymal stem cells, at least theoretically.
Yes. So
one more question.
Yes.
So we are all arthroplasty surgeons, and most of the time when we do this patelloplasty, when we take out the osteophytes around the patella, you can see the fibrocartilage covering the patellar surface. Probably that this cartilage injury might have happened somewhere 20, 30, 40 years back. But that was so most of the time you won't be seeing any lesion in the surprisingly you won't see any lesion in the patella. So most of the time this patellar cartilage loss might have healed with this fibrocartilage. So the healing potential to do this even without this microfracturing in that patella, if that lesion, that crater is healed by fibrocartilage. So if you put some microfractures, the healing potential is amazing. And I don't know these the Western papers saying that after 5 years the results will be bad, but I had this opportunity to rescope 2 or 3 cases after by microfracturing, and surprisingly all 3 were completely. The only thing, some cartilage, the stuffs of hair-like things was there on that area, but the lesion was completely healed, completely covered with fibrocartilage.
Is it the fibrin which make this blood to be keep it there for long period, or what is the?
In fact, this Indian Cartilage Repair Society, they have included one more thing: the adding of biologicals. So biologicals like those things also. If you do this microfracturing and if you add this biologicals, probably that also will help healing of the cartilage. And so they have different thoughts, but the majority was saying that biologicals adding it is good.
If there is no more talk, we will go to the next And the next topic is newer methods of cartilage repair. As we all know, the stem cells and the cell-based and autologous chondrocyte implantation and AutoCAR. Regarding this, the speaker is Dr. K N Subramaniam from Madurai Medical College. He is a well-known speaker and a well-known person in Indian Arthroscopic Society field, and is a very lead role in most of the national arthroscopic conferences. Welcome, Dr. Subramaniam.
Thank you. Sujit, can you hear me?
Yes, you're audible, well audible.
Are you able to see
We
my
can
screen?
see your presentation. Yes, we can see your screen as well.
Okay.
Please.
I'll start presenting. If there is any hindrance in between, just call me in my phone, okay? Yeah. So, first of all, I would like to thank our Arthroscopy Association of Kerala for giving this opportunity for me. And thank you, Dr. Schiller. I don't know whether he is in the participant group now, but thank you him. Thank Sujit for organizing such a nice conference, and thank you all the Kerala Arthro Society members. Yeah. So the topic given to me is a newer method for cartilage regeneration. We are going to take three things: BMAC, ACI, and AutoCAR. Out of which I have done more BMAC. ACI I have done few cases in the past, but recently I'm not doing very much. AutoCAR, very little experience, which has come recently only. Okay. So I think first thing we need to know is about why all these things. Cartilage science has always been like very controversial. The basic reason is we are not able to reproduce the vascularity of the cartilage tissue. That's why so many procedures comes in, and each has got its own success rate and failure rate. Early stage of chondrocyte injury, there will be some cellular and metabolic changes. Usually hydration starts changing, and fibrillation starts becoming disorganized, and transmission of impact load to damage cartilage becomes much more bigger. Then they start becoming partial thickness defect. Then they'll slowly get into full thickness defect. And once the full thickness defect goes into subchondral area that penetrates subchondral bone, and then the allo regeneration of type 1 collagen And one thing very important message I want to give today is when you are dealing with any cartilage problems, try to look into malalignment issues. If they are having malalignment issue, I think they need to be addressed first. And anyone who had a total meniscectomy or partial meniscectomy, but also has to play a role. We need to address those things before embarking on a cartilage surgery. And any ligamentous surgery, which is either ligament absence or ligament rupture, that also has to be addressed. It's very important to understand that cartilage relies on all these other tissues, which actually helps to you stay as a fulcrum for cartilage to stay there when you do the regeneration technique. So, if the regeneration technique is done and if the alignment is not right, then it is going to fail immediately. Within a few years, you will start failing. So imaging, I think Jyothi mentioned very clearly about how we can see. So I'm going to skip this slide. And don't miss about the root tears, which are very common nowadays, which we see it. And patients coming with root tear and middle compartment OA are not very common, not very uncommon. And try to address root tear also at the same time. And alignment is a very important thing. And I have to say that though microfracture has already been described, for any procedure I do, whether it is a BMAC or ACI or even AutoCAR, I do microfracture to start with, and then only do other procedures on top of that. So other procedures are an additional advantage on top of microfracture. Microfracture is already known to have about 40 to 50% success rate, so it produces fibrocartilage. Other procedures, BMAC has got about 60 to 70%, ACI has got around 70 to 80%, AutoCAR has got in a similar range. So the success rate, none of them has got 100%. That's something we need to clearly understand. So this science is still evolving. Still, we have not come to a conclusion yet. And where to choose cartilage regeneration, when to choose is the symptoms have been very relevant to the cartilage lesion. Somebody should come with a very focal pain in the medial femoral condyle, then I would take those patients. Somebody who has got a sports injury, a young person who has got traumatic injury, then they are the right candidates. Not the one with the degenerative. Somebody with degenerative cartilage changes, they are not a very right candidate for doing all this ACI and all. Because the ACI is indicated in persons who are like a 20 to 30-year-old, who is a football player, who has got a focal injury, who has got a very good blood supply underneath. Then if you do ACI on those patients, those who are like ideal indication for getting a good result in this in the final outcome. So to do surgical intervention, there should be a persistent symptoms, and there should be failure of non-operative management, and the patient should be good compliant for recovery and rehab, and they should be explained about ultimate functional outcome very correctly, and concomitant pathology should be very well dealt with, and one should know the risk factors like smoking, obesity, and elderly are not the right candidates for doing all these procedures, because these procedures are expensive, and you cannot expect a satisfactory result if you have all these combinations. So one has to be very clear about all these things before intervening all these procedures. Let's take BMAC, and then I'll go to AC, and then I'll go for the autocar. BMAC is actually quite simple procedure, because we take from the iliac crest bone, take aspirate from the bone marrow. Sometimes we take up to about 60 ml of blood from the bone marrow. And the most important thing about is taking the right cells. The right cells are not there, then the chance of success rate is not very good in BMAC. I actually seen my own patients after I had done rescope or some other reason, you found out only fibrocartilage there, and even the fibrocartilage is only having in patchy areas. So BMAC may not be very successful if the ideal cell counts are not there. So that is something very difficult thing to measure also, which I have noticed in a later stage. So recently stop doing BMAC for many patients. So easiest site is to post-reciprocal spine for harvesting, where you can easily take the blood sample from there, and you have to go right up to about 2 to 3 centimeter of bone marrow tissue, and use heparin in the syringe so that it won't become clotted, and use on the centrifuge machine. In the centrifuge machine, you have the 60 ml of blood put into that, and there will be 2 layers come. First will be one buffy layer comes up that will have more of plasma. And after taking the buffy layer out, you have to redo it again. So 2 times they will do the centrifuging, and the final one will have should have the right cell count. We don't have the normal routine practice of seeing the cells in the microscope, but ideally we should be doing that also to make sure the ideal type of cells are available in that, because these are all totally depend on how good the cells are. If the cells are not there, then the biology is not going to work at all. Advantage is easy to technically easy to harvest, and it's a single stage procedure. There's no need of culture and all, no risk of disease transmission, and can be performed along with the concomitant procedure. So not uncommon, we do along with the HTO, we do BMAC, with the root repair, we do BMAC. So that can be done as a concomitant procedure also. But disadvantage is the potential pain during harvest and variable stem cell quality and quantity. That is something very important about this, and potentially detrimental effect of erythrocyte used in intra-articular environment. If there are erythrocytes, that can cause harm to the intra-articular environment also. So that is something one has to keep in mind. What is the evidence of BMAC is, you can see that up to 5-year follow-up, they have been shown to have good improvement, but beyond 5 years, they start declining. So something like microfracture is slightly better than microfracture. As you can see that after 5 years, the results start, the sustainability of the result that you got in the first 2 years may not be there in after 4 or 5 years, because the patient will again start going into some cartilaginous lesions and start developing into osteoarthritis also. That is the current evidence of BMAC. We go into ACI. ACI is a very popular technique. When I was in UK about 15 years ago, there was one gentleman, James Richardson in Australia, who was routinely doing ACI, and he was demonstrating about 70 to 80% success rate. The whole concept is you take a piece of cartilage and grow it in a lab, culture it, and make it to 48 to 96 million cells, and inject the place where you have that defect. That is the whole concept. When you are injecting the cells may fall apart, so you make a membrane there and inject under the membrane so that you will have the live chondrocytes into the defective area, and the defect area will be covered by the normal hyaline cartilage. That is the whole concept. And it is successful if the indication is correct. So ideally, we choose an indication of focal traumatic lesion, which is more than 2 centimeters, because less than 2 centimeter one can be nicely dealt with OATS. OATS is an exactly very nice procedure actually. OATS, the success rate is very good, and you can see almost like a normal cartilage. But the only problem is you cannot put in like 3 or 4 centimeter lesions. So for these lesions where 3 or 4 in the ACI is a very nice procedure where you can try, especially in the trochlear patella. In patella, you cannot do OATS at all. I've not seen patella having done with OATS because it's only done in medial femoral condyle nicely. So other areas you can try with the autologous chondrocyte implantation. But there are certain contraindications, more than 50% loss of cartilage thickness, inflammatory joint disease, unresolved septic arthritis or metabolic disorder or deficient soft tissue coverage, like anyone who has got open injury, and patients, smoking patients, obesity, chronic narcotic use, non-compliant patients, age in elderly individuals, and those who are allergic to collagen. These are very rare allergic to collagen, but other things should be taken into mind. Like current smoking and obesity should be taken into mind. And those kind of patients don't ever advert into going for any biological procedure. The chance of healing is very, very high. And do preoperative planning. Check for the alignment and make sure the alignment is has been corrected, or the patient has got a neutral alignment or a say 5-degree valgus alignment. And always do a long leg view to make sure we are not missing those issues. And assess arthroscopy to see the cartilage biopsy area, and take biopsy from the non-weight bearing area. The usual site of biopsy is somewhere around the trochlea area, where you can take a good amount of tissue on the trochlea area, where just on the border of the ACL and PCL attachment, you can take those good chunk of tissue, or sometimes you can take from the border of the anterior femoral condyle in the lateral side, where you can take same site where you can take the warts, where you can take a sample from there also. And usually they ask only small samples only, and they take it to the lab for about 5 to 6 weeks. And because it's a 2-stage procedure, that actually becomes a little difficult to explain to the patient. First time we take a biopsy and then send to the lab, and they come back in 5 to 6 weeks time with the grown-up tissue, culture tissue. And then you are doing an open arthrotomy. And I have not done with the scopy. You can do the arthrotomy because most of the lesions we are doing like patella or the inaccessible area with the scopy. And you don't want to use saline when you are injecting the cells. So we don't want to go through the scopy method. So we are doing the open technique. The open technique have access to it and do nice preparation of the bed. You can actually do microfracture also same time to have more cartilaginous or mesenchymal stem cell element, and they do nice curating, and then they supply with the membrane also, stitch that membrane along the sides and make sure you have that area fully covered, and then through the superior area inject those chondrocyte cells, and so that you fill that defect with the whole chondrocytes. And the patient has to be on the non-weight bearing for a period of about 4 to 6 weeks. Usually take 18 gauge needle to fill that. And usually you will see the nice filling up of the tissue and leave it for about 5 to 10 minutes, and then you can start closing the knee wound. So you have to protect the graft for about 6 to 12 weeks after surgery. So they have to be on non-weight bearing and no range of movement for that period. And up to 2 to 3 weeks time, you can start doing static VMO exercises, but not the range of movement exercises or not the weight bearing. So weight bearing should be protected, should not be done for about 6 weeks. After that, you do protected weight bearing for another 6 weeks. So this is the normal rehab protocol for the ACI. So after 12 months, you have to think about doing sports. So these patients most of them are professional athletes. They have to bar them for doing sporty activity for up to about 9 to 12 months minimum. So you have to have that mindset for the patients who are coming for this surgery. So that's why I told initially itself, the patient counseling is very important. So it's a 2-stage procedure. It's expensive also, but harvesting is not difficult. Occasionally, you can do possibility arthroscopic repairs, especially in the medial femoral condyle lesion, where you can do with a dry scope. That is possible occasionally only, but majority I have done only open procedure only. But the problem is the evidence says that about 70% success rate at about 10 years. So it's not 90% or 100%. This also start weaning off after a particular period. So, but up to about 10 years, that is the time for the professional athletes to for their matches and all. So that will kind of withhold for that 8 to 10 years time, and then it weans off. So they will end up in again the degenerative part of arthritis at about 10 to 15 years time. They will have the sustainable results start going down. Now let's go to the AutoCAD. AutoCAD actually recently Jian's Salzman was there in a meeting in Mumbai. So I've taken some of his slides also. So here now it has become a little popular because being told as a single stage procedure, where what you're doing, you're trying to take some cartilage tissues out, The same sitting, those cartilage tissues are minced into several pieces. We can sometimes mix with some bone marrow also, like some small cancellous bone pieces, and make it like a paste, the fibrin glue, and you can inject to the site where there is defect. And this is called AutoCAD technique. Okay, this is come with various companies, but AutoCAD is one of the make. And healing triad, the one has understood their growth factor, matrix is there, and regenerative cells. All the three are there. So the current science claims that all these three together makes that cartilage environment to grow very well. What are the three things is ACP, or the cartilage autologous conjugate plasma, is a matrix. Regenerative cells are the cells that we are taking out, and growth factors are the one that we are also injecting on top of that. So all the three working together can form a nice cellular area which can mimic almost like a normal cartilage. There is a science behind it. So the harvesting and then mincing the cartilage and then filling the defect and fixing with the fibrin glue. These are the four major steps in doing AutoCAD. And the good thing and bad thing is it's a one-step procedure, and we are replacing by chondrocyte itself. It's not by replacing other tissue and we're expecting for the stem cells to grow. It's replacing by chondrocyte along with other chondrogenic factors also. And we can do it by arthroscopic implantation itself. You don't need to do open surgery. And the disadvantage, exact quantity of particle cartilage harvest for optimal outcome not yet clear. So, for example, for this much of defect, how much cartilage should I take? It's still, that fact has not been shown clearly in the science. So what we are doing, we're trying to take as much tissue and trying to put as much tissue as possible in the defective area. So, for example, if I have an idea, 1 centimeter tissue, this much I have to take. This is not been very clear in the science still. We are just trying to do as much tissue as we can that we are doing at this moment. Evidence for AutoCAD is, the problem is that this AutoCAD technique has been there only recently over the last about 2 to 3 years time. But the papers from Western countries have shown that they have a satisfactory outcome at about 2-year follow-up. But longer follow-up and larger cohorts are required to tell about how good is going to be there in sustainability terms for about 5 to 10 years, so that we do not know. That is the main downside of the AutoCAD. So this is like some case where you have to see valgus, whereas deformity is not there, meniscus tear is not there. These are there, that has to be addressed also. The case where you are showing through the AutoCAD technique, you are denuding the cartilage, making sure the subchondral bone is nicely visible, and then injecting that minced cartilage along with the glue to fill up at the space, wait for the cartilage to nicely become like a paste, and then close the wound. So this is the one picture which shows like after about 1 year time, there is a good nice growth of the change of the cartilaginous area, as if almost looks like a normal cartilage. That has been shown in literature. The comparative standard for the AutoCAD is other areas like ACI or BMAC or other procedures. And the literature has shown that they have almost equivalent report. But ACI is expensive on 2 stages. But BMAC, the AutoCAD is showing almost similar result like ACI, though it's a single stage and it's less expensive than ACI. So it is shown that it is equally good. And the current studies have all shown that it is shown about 24 months. Studies have shown that they have a very good outcome. And these are the described techniques where you try to mince the cartilage, and you can mix some bone also along with the cancellous bone, and dry it with a dry arthroscope if you are doing it arthroscopically, and you can paste it nicely over the defective area. So for small bony defects, you can use allogenic bone chips also. That has been described in the literature, but I have not done allogenic bone chips. But you can use that also as available in the market. And this is another example shown in the literature where you can use the allogenic bone chips along with the cartilage chips and along with the fibrin glue also, so that it make a nice paste and cover the whole area of the defect. And some people are using membranes also in order to hold that. That has also been shown in the literature. But to summarize, fragmentation should achieve the smallest possible chip. So smallest in the sense less than 1 millimeter. That gives a chance of more incorporation into that defective area. And sharply cut and avoid crushing the cartilage during particulation. Fragments should be quick, controllable, and highly standardized. Optimal fragmentation promotes outgrowth and differentiation. Mincing devices hold potential to fragment in a fast, effective, and highly standardized manner. Fixation can be performed by a fibrin glue. That's what we are commonly using. You can also use hydrolyzed membrane coverage, potentially augmented by PRP or platelet for plasma. These are like literature showing MRI showing the almost regrowth of a normal cartilage, which is taken 6 months down the line. So for this discussion, single-step autologous minced cartilage, otherwise called as AutoCart, represents a possible alternative to ACA procedure. Nevertheless, clinical evidence has shown evidence for a short-term results only. Supports the notion that minced cartilage is a safe procedure. Published studies have shown satisfying clinical outcome. Failure and revision rates are comparable to other available cartilage repairing techniques. I think more trials are needed to come with more strong evidence of how the AutoCart is going to be in the long-term outcome data. So just to summarize for professional athletes, a small defect means you go for GOATS, medium or large defect means you go for AASK or AutoCart. Just to summarize, cartilage repair is still a science of ongoing research. Various modalities have been described over the last 2 decades. BMAC is promising, but the outcome depends on cell quantity and quality. And long-term, the results are not sustainable. AC is very good, but 2-stage and usual success rate is around 70% in 10 years. AutoCart is a new procedure, has shown good results, but has shown only short-term results as of now. But time will reveal the full effectiveness of it over the next 5 to 10 years' time. With this, I conclude the session. I would like to thank the whole Arthroscopy Society of Kerala for giving this opportunity. Thank you very much.
Thank you, Dr. Subramaniam, for enlightening us about the latest techniques of treating the cartilage lesions. From this lecture, I came to know that the treatment for the cartilage lesion depends on the lesion-specific characteristics as well as the patient-specific characteristics. But even with these latest techniques, we come to the conclusion that the durability or sustainability of the results are still dubious. So newer methods has to come to cover the deficits so far in the treatment methods for cartilage lesions. And the topic is open for discussion. Any questions regarding the newer techniques like BMAC, AC, and AutoCart?
Definitely, I think still we need a newer procedure. All these procedures comes in the market like marketing gimmick, but we have to be really careful before using it and finding how successful it is and then start employing to our patients.
Question to Subramaniam sir. Hello.
Jyoti, tell me. Yeah.
Yes, sir. Is there any dimension specific for AutoCart that is above that you can't do that like that? Any dimension?
I think the most of the time we are doing for 3 to 4 centimeter defect. Smaller defects we manage with OATS. Even myself, I do OATS only for smaller defects. 8 mm plug, 6 mm plug, put 2 or 3 plugs, you can cover a nice 2 centimeter one. The bigger defects only we are doing 3 centimeter defect, we are doing that. And especially the medial condyle defect. To quantify how much cartilage to take is you try to take more. There is no way of quantification by an objective way at this moment. That will be the answer for your question. We are trying to take as much as we can and try to take like 1 centimeter. That you can see in that the container they give almost half of it like that.
Cartilage. So you want to inflate with some gas or anything?
Yeah. Yeah. What we do is I've done like techniques where you can use carbon dioxide, okay, as a laparoscopic sensor use. But you cannot use it for longer time. You use it for short time. But sometimes you can just do with the dry scope. Even without using any kind of gas, you can do it also. That is also possible. You have to have that small potty sponges in your hand. One side you have the suction, and the other side you have these patty sponges rolled up nicely, and try to keep on drying it, and then inject this.
Okay. And this
medial contact is doable.
BMAC, you are directly injecting into the joint after preparation.
With the lesion.
Say that again.
Are you directly injecting this BMAC, bone marrow aspirate concentrate directly into the joint, just like any other intraarticular injection?
Directly into the joint. I mean, for that I do PRP like that. Okay, directly inject into the joint. Bone marrow aspirate, I'm not directly inject into the joint. We make it inject to the fibrin glue. The fibrin glue will form like we have a syringe, will have two syringes. One syringe will have a fibrin glue, other syringe will have a for the lesion.
Actually, the PRP theory is different. Here, the bone marrow BMAC, the concentrate doesn't contain any platelets or leukocytes, like that. Is it, Dr. Subramaniam?
Bone marrow, yeah.
The fluffy cord doesn't contain platelets or leukocytes. That's the difference between PRP and the BMAC.
Correct. PRP has got only platelet. This one has got additional growth factor. They will have transforming growth factor. They all will be there in the BMAC. That's what the science says. But I am actually not fully convinced about BMAC. When the BMAC came in, BMAC has been there for about 7-8 years now. I was using very much for initially about 5 years ago. I used for many cases. There are few papers which came up saying that BMAC is not much different than microfracture also. Few papers came up. So after that, I stopped using it. But PRP were injecting cases. But the AutoCAD is now becoming a little popular.
In some literature, I have seen some car gel. There is a word like car gel. Is it something related to? You heard about that?
Scarring.
Car gel. Car gel. No idea. I have read somewhere.
Scarring.
No, car gel. CARGEL. Any something related to some scaffold?
So you need to Google it.
Maybe.
I'm not aware of it.
Okay, sorry.
And sorry, if you know, please enlighten us.
Anyway, I just that's all. The name car gel. That's all.
Car gel.
Maybe some biological scaffold.
Okay. Yeah.
Sir, can I ask a question?
Yeah.
Sujit.
Yeah. There used to be a scaffold called TrueFit, which was commonly used for cartilage defects. Can you tell me the current status of such scaffolds, sir?
Scaffold for
scaffolds for cartilage defect. Smith & Nephew used to produce a scaffold called TrueFit, and probably we have done quite a few number of TrueFits, but suddenly they vanished from the market. So, what was the reason, or do you know why it was withdrawn from the market?
Even now, there are some cartilage pastes are available, like a paste like. It will form like a scaffold. Scaffold is nothing but making a platform for the cells to grow. Okay. I think the main reason these scaffolds are not standing in the market is they are not bringing the real vascular tissue. They are acting like a platform, but they are not showing the viability on a long term. Hence, they are not able to sustain in the market. And this will be holding true for cartilage paste is also available. I think it is becoming much popular because it's not showing the long-term results. And as you say, the TrueFix is like a cement bond, is it, that one? Because I have not used it myself. It is like a paste where you inject over there, isn't it? Okay?
The TrueFit actually comes like just like say scaffold which is available in different sizes. So
Yes,
what you do is you prepare the recipient side just as you do it for OATS, and you just plug in this particular scaffold which is available and ready-made.
It's like a paste, isn't it? Yeah.
It was not like a paste. It was just like a hard substance. Like just like
Okay,
we
okay.
put the oats, it
Yeah,
comes
yeah,
as
yeah.
a scaffold. It was not a
Okay.
paste actually. So suddenly it vanished from the market. I don't know what happened.
No, no.
But
The
we did quite a few cases.
problem is scaffold is just a platform, but we
Yeah,
need viable cells, isn't it, for
yeah,
the physiology to occur over there.
yeah.
If that is not there, automatically
That could
the
be the
will fail, isn't it, at one point.
yeah.
That's
Right,
what I
right.
think.
Yeah, probably that was the reason. Thank you.
Thank you.
One doubt, Dr. Subramaniam. When doing ACI, whether we have to drill the subchondral bone or we have to keep it intact?
I think two school of thoughts. Some people just do scraping and then expose the subchondral bone and do it. But there are some people who do minor, not like that 3 mm hole, because normal microfracture will make 3 mm hole. You just make small 1 mm holes like that, multiple holes, and do inject over there. Both can be done. In the past, I have done ACI. Recently, I am not doing ACI. In the past, I have done. I used to make small holes with 1 mm biopsy.
Sir, one more question.
There is a dental pick available in the fracture fixation set. The dental pick. They have a fixation set. I used to use that. That is only like 1 or 2 mm. Make small punctures over the fundal bone.
Sir, one question. Sir, hello.
Yes, please.
Hello. There is evidence that is while doing an ACL, if you repair a meniscal tear, there is high chance of healing. So, is there any evidence that any cartilage lesions will also heal simultaneously with doing an ACL reconstruction associated with the cartilage lesion?
I think there won't be much literature about it, but I think logic says possible, isn't it? Because you are stimulating the marrow. ACL is you are stimulating the bone marrow by making a tunnel. Okay, and when you are making a tunnel, you are showing a lot of stem cells or mesenchymal cells in the cartilage and the cancellous bone will come to the knee joint. So that might be potentially helpful. That's what the logic says. But I don't know the literature about that.
Even for AutoCAD, they say the recent ISA course, they're saying the microfracture has to be done. Initially for AutoCAD, they never used to advise microfracturing. Only scraping was advised initially. But now microfracturing with the ACP, thrombin, fibrin glue, and the cartilage. It fills up the defect is the better results. Maybe it's evolving, as you said. We need more better things for cartilage.
And AutoCAD seems to be a good option for patella. Mostly when the patients deny 2 times this thing. I had done one AutoCAD and it was a really nice experience for the patient because the entire pain was gone. So for patella, we can't opt for much of another procedure. Rather, or maybe OATS might not be possible, and the patient might not afford a 2-stage procedure. So if the option of AutoCAD is given for a patella, then definitely it might give a good result.
I have to frankly say that I do microfracture for all these patients, whether they are BMAC or AutoCAD. The hidden reason behind for me in my mind is okay. These are all like newer procedures. Whether all these AutoCAD or BMAC or all like a newer procedure come recently, but microfracture is known to be there for 20 years. If these procedure at least fails, we have at least microfracture to work. That is a hidden reason behind in my mind. So I do microfracture for all these patients before putting any biological substance over there. Microfracture, we know at least 40 to 50% success rate is there. If everything fails, at least that will work. And that concept is there in my mind. That's why I do microfracture. And
microfracture. Sir, any experience on this nanofracture thing? That is, I read it only. I have not done it.
It's a good idea what you're telling in nanofracture because the deeper structure is the real mesenchymal stem cells, which may be much beyond 5 to 6 mm. So our microfracture all doesn't go to beyond 5 mm anyway. So, I think that is a good idea, nanofracture. Maybe when you are doing with the K wire, I mean, some people do with the K wire microfracture, okay? They drill beyond 5 mm anyway. The reason why we don't use K wire is because of thermal necrosis. That is the reason people are not using K wire, but that is also an accepted way. 1 mm K wire will do like nanofracture only.
But if accidentally that 1 mm K wire gets broken and gets inside, then it's a big problem, I feel.
There is no more question. Shall we conclude? Okay. I thank all the speakers for the very informative talk, and I thank the ASK team for giving me this opportunity to chair this section, and thank all the participants in this joining this webinar series. Thank you and then Dr. Sujit, please conclude.
Yeah, thank you, Dr. Rajesh, for chairing this session and conducting it wonderfully well. Let me thank the speakers, especially our national speaker, Dr. K N Subramaniam, who's a well-known surgeon from Tamil Nadu, and you did a wonderful job. We had this the topic in our mind for discussing cartilage lesions once in our ASK wisdom trail, which we conduct every month. And cartilage is one important area where there are so many gray zones and confusions about what to do when and what works well for your patient, especially at what age, for a younger patient, for a middle age, for an older patient, when to call old. And it was all well described, especially Dr. Jyoti's talk of picking up cartilage lesions in the MRI. Because that is one particular problem we always face. The radiologists are very much focused on the ACL, PCL, the meniscus lesions, the collaterals, but then a cartilage lesion on the medial femoral cartilage is often missed, very often missed. It is a sad truth. And we have to train ourselves to look at the cartilage lesions to pick up cartilage problems. Otherwise, when you go in to repair a meniscus or ACL without looking at the alignment, the problem can definitely go out of your hand. Your results can be affected. So, thank you, Dr. Murukan Babu, for wonderfully enlightening us, and all the people who joined here today. Let's meet again next month. Every month, third Wednesday, we meet for an hour to discuss one focused topic on arthroscopy. So, thank you all. Good night.
Thank you, Dr. Rajesh. Thank you, Sujit. Thank you, Murukan Babu. Thank you, Jyoti. Thank you, everyone.
Thank you, K N, sir. Thank you so much.